and I'll turn it over to Kim Buckley. Enjoy.
Thank you, Susan. Good afternoon, everyone, and welcome to the HASP class called the Past, Present, and Future of COVID. The class is being conducted by Jacob Steer Williams from Charleston, South Carolina. Jake is an associate professor of history at the College of Charleston. He's the author of numerous scholarly articles on the history of disease, public health, and science, and has also written extensively for popular audiences. His book, The Filth Disease, Typhoid Fever and the Practices of Epidemiology in Victorian England, was recently published. Jake is also the editor of the Journal of the History of Medicine and Allied Sciences, published by Oxford University Press. So Jake, without further ado, I'm going to turn it over to you. Welcome.
Here's my window dressing for the day of my book that's just come out. Thank you so much, Kim, for that kind introduction. And I'm so pleased to be here with you today and to share some observations on a topic that everyone has observations about. And what I want to do for you today is to give you some thoughts and some reflections about how someone like myself, a historian of pandemics, has thought about and thought through this moment that we have been living through in the last year and a half, and that we will continue to live through. So hopefully these are observations that will resonate with you, but maybe also offer some different perspectives for you at the same time. So I look forward to your comments and your questions and observations, because these are ongoing conversations. So for the past 10 years, since the time that I've been at the College of Charleston, where I teach classes in the history of public health, history of science, and history of disease, I've ended as a last lecture my undergraduate courses with a kind of warning to undergraduate students. And what I've come to see as a kind of old guy hand-wringing. And what I say in this last lecture is that at some point in your lives, 18 to 21-year-olds, you're likely to experience a pandemic, not unlike the ones that we've spent the entire semester exploring. And so early last year, when reports of a novel coronavirus emerged out of a single province in central China, I began starting each class with world news reports and early laboratory findings. I actually first learned about SARS-CoV-2 through Twitter, of all places, which is, I've been sort of trying to rewrite my own history of the pandemic as well. And my own personal story is that one of my friends is a Greek guy. He's a disease ecologist who works at the University of Edinburgh in Scotland, and he does a lot of field work as a specialist in zoonotic disease, so the transfer of diseases between animals and humans. And a lot of his field work takes him to central China. And my friend Christos is colleagues with some of the Chinese virologists who were the first to discover this new variant of the family of coronaviruses that we've known about for some 40 or 50 years. And Christos started tweeting out messages about what his colleagues in central China were saying, these virologists, and I started following what he was saying long before there was any of the global news reporting about this potentially new disease. So instead of playing music or chit-chatting with my class before we began, I started pulling up my Twitter account and seeing the science unfold in real time before there were even news reports about it. And that was a really eye-opening experience, looking back pedagogically in the classroom, of being able to see the science of disease unfold in real time. And it reminded me of something very prescient about the study of disease, both in the past and in the present and in the future, is that it's often hardly an academic exercise to study disease and public health. And since that time, in the last 2 semesters of teaching, just like I am right now, virtual teaching to undergraduate classes, during the fall of 2020 and in the spring of 2021, I've realized something that I haven't had to deal with, and that is now in this moment, this COVID world that we now are in, inexplicably. I don't have to explain even to young people, to 18 to 21-year-olds, why we should care about the history of pandemics. Usually I have to make the case to them. And usually how I make that case is by saying, you will probably experience a pandemic in your lifetime. But now that we collectively have experienced that pandemic, people want, and in some ways, I think in a deep psychosocial way, need context. They want the historical context to be able to better understand the world that we inhabit right now with dealing and struggling and living through a pandemic. I can't tell you, even in 2 semesters worth of teaching the history of disease and pandemics, how many student comments that I've gotten back in my evaluations that just said, I feel like I can finally understand the hellscape that we've been living in because of taking your class. Students that said, I've lost family members, I've lost friends, and I've found it difficult to process that. But taking this class and learning about the history of disease has helped me to humanize my own experience and my own emotional experience of the pandemic. And that's been really powerful to me, more powerful than any classroom experiences that I've had in a decade now teaching the history of pandemics while living through a pandemic. And going forward, to go back to this initial point, I don't have to, I think, ever give this last lecture, or maybe it'll take 20 years at the end of my career before I have to give this last lecture again about an impending pandemic. And it's clear where we sit today in July of 2021 that, at least in the US, we're transitioning to a new phase in the COVID-19 pandemic. And I think from my perspective as a historian of disease, and in particular a historian of epidemiology, it's no longer appropriate even to call the COVID-19 a pandemic. It's really an endemic disease right now, epidemiologically speaking. It's a disease that's part of our world. It's spread across the globe. It's morphing, it's changing, it's adapting, and it's unevenly striking in epidemic waves. But it's now just an endemic disease of our world. And so this last year and a half, as I've been trying to process it in real time, it's been really Janus-faced for me, to use a Greek metaphor. On the one hand, I've experienced the pandemic as a scholar of pandemics, and I've had to put on constantly for public lectures like this, for leading a university task force, and for teaching classes on this topic. I've had to wear my scholarly professional hat to process the pandemic and to anticipate, and this has in some ways been the hardest part for me, is to see and expect both the best and the worst parts of our collective humanity that are exposed during a pandemic, that are illuminated during a pandemic. What I like to call in my classes, and what I've called in my research, the usual patterns of how we as human societies deal with pandemics. We name, we blame, and we forget. And those historical constants that exist in historical thinking are at once, I think, different than the real life experience that I and you all have had of just dealing with a pandemic. And as an everyday person, my wife, my partner, she works in the emergency room of MUSC, which is the biggest hospital in our state and the biggest and the oldest teaching hospital in the American South. And for months in early 2020, she was interacting with COVID patients every single day. We had to set up in our garage a kind of mobile disinfecting station with the rest of our family not being vaccinated and our 2 children still not being vaccinated. And so there was this real tension in my own life as somebody trying to process what we were dealing with using the tools that I've prepared myself to do my entire career. And then also at a really deep psychosocial level, just dealing with the pandemic like everyone else, and all the fears and the anxieties. And I want to talk about that a little bit here today, that what I think we could describe as a kind of philosophical dissonance that I have experienced, but I think in some ways we all have experienced, that thinking about the past and the present and the future of COVID-19 is something that we all deeply should care about. And I want to explore some of the reasons that I think the lasting resonance of the last year and a half are going to have on the rest of our lives and on the tenor of American society and in global society. And I want to ask really three questions of us today. Where do pandemics come from? How do we experience pandemics? And how do pandemics end? Everyone knows that pestilences have a way of reoccurring in the world, yet somehow we find it hard to believe in ones that crash down on our heads from the blue sky. That's a quote that I keep coming back to that may be familiar to some of you. It was written by Albert Camus in his famous novel, The Plague from 1947. And if you've never read The Plague, I highly encourage you to pick it up. It's an easy read, but this year, a year and a half, it's proven to be a chilling read because of the kind of historical truisms of how this pandemic event is shaped and framed by Camus, and how much resonance there is for what we've experienced in the last year and a half. So what did historians like myself of pandemics see coming before COVID-19 emerged? If we were not surprised, and I would suggest to you that in some ways I wasn't surprised by COVID-19 coming down and crashing on our heads, to use Camus' phrase, what are the discernible patterns of behavior surrounding pandemics that we might have predicted, and that I think a lot of us have predicted? So what I can say, and this is another sort of interesting pedagogical moment for me, is that in the last 10 years, I've used some version of a final exam question that goes like this. If a new pandemic emerges, who will be hardest hit in the US and who will be hardest hit in the world? And I've just asked that as a final exam question. And you will not be surprised if I could give you samples of student essays for the last 10 years that they have said that people of color and minorities will be the hardest hit in the US and the global South will be the hardest hit in the world, because the history of pandemics has time and time again shown us, both in this country and throughout the world, that has been the pattern. I think I'm going to have to come up with some new exam questions probably after COVID-19. And what a historical approach offers of helping us to understand pandemics and thinking through the historical archive on pandemics is a series of what French philosophers and historians call longue durée, long periods of time, and understanding large frameworks of patterns, whether they be truisms or idiosyncrasies of our time and place. And I always like to tell students that part of the historian's central task is empathy, is really trying to understand the way that people felt at any given time in the past, to understand the broader causative forces at play. And with pandemics, you know, we could say at one level that the causative organisms of epidemics, they're inextricably tied to us, to our bodies, to ourselves, to the human condition. And that's in some ways studying the past is comforting to learn about past pandemics in a kind of bizarre way. And it helps, I think, to erase the urge to essentialize our experience as the only experience of pandemics. And that's something that I keep coming time and again back to in talking to people about COVID-19. You know, we experience disease and we experience pandemic at the level of our communities, our family, our friends, our circles, our coworkers and our colleagues. But pandemics are by their very nature global events. And I think it's very difficult at an emotional level to both be experiencing a pandemic for yourself and your own world around you, and then also realize the depths of the humanity that we are all experiencing at once. And there's a lot of fascinating psychology research coming out of psychology on trauma and epidemics, and the way in which what we've all experienced across the world in the last year and a half, and many people are continuing to experience, is very real trauma at a psychological level. And that's really fascinating to me to reflect upon. modern societies in the West have tended to certain behaviors in times of epidemic crisis. And despite the urge to reopen states and reopen nations and economies, we're still in the midst of a global epidemic crisis. While our responses, both today and in the past, have not been uniform, I think by any stretch of the imagination, there are some patterns. We saw it in the US, patterns to deny, patterns to name, patterns to blame, patterns to scapegoat, what we might call, and what I like to call, the politics of naming disease. And just to give you an example that everyone here is familiar with, that we saw in 2020, politicians like former President Donald Trump repeatedly calling the novel coronavirus a foreign virus, indicating that it's something that's not ours. It's from someone else. Someone else is to blame. A Chinese virus, a Wuhan virus, or the blatantly xenophobic remark that has drawn so much criticism from scholars and citizens alike, Kung flu. Historians of pandemics have found these remarks deeply painful, of course. And what we've seen in the middle and the late of 2020 is a very real statistical uptick in the past year in the US of anti-Asian violence. But framing a pandemic as other and foreign is part of a long historical pattern. And there's a deep and difficult history of xenophobia being what I like to call, and what I always tell students, xenophobia is a kind of first responder to epidemics. When an epidemic starts, what do we, particularly in the US, although not exclusive to the US, what do we like to do? We need to find someone to blame. And we saw that repeated when COVID-19 emerged. Historians of epidemics have long been attuned to the idea that epidemics are sampling devices that bring to the fore cultural attitudes about citizenship, who belongs and who doesn't belong, about governance, issues of rights, and about science and the communication of science. Historian Charles Rosenberg, who is, he's now emeritus at Harvard, but for most of his career, he was at Penn. He went as far as to say in his work that in some ways, it's a provocative claim that disease doesn't exist until we agree that it does, by perceiving, by naming, and responding to it. And of course, Rosenberg, like everyone else that studies this field, doesn't deny the biological reality to disease, of course, but just understanding a disease's biology or its ecology or its epidemiology doesn't tell us what a disease is or how we understand it. So in other words, that diseases are cultural phenomenon just as much as they are biological phenomenon. And this model or this approach or framework to understanding disease is a kind of useful hermeneutic loop, I think. It merges our understanding and engagement of pandemics. Rosenberg has even described pandemics, and this has been a useful kind of trope for scholars studying pandemics, as having a dramaturgical quality. Epidemics begin in a time and place. They have a stage. They reach a climax, and then they in an intensity, and then they fade away and they end. And it's been an attractive kind of idea of bounding epidemics in time and space. But it's one that I've also been really uncomfortable with in my study of pandemics. And I'd like today to give some observations of how such an approach needs to be rethought and is being rethought in the scholarly literature, but also is something that for all of us as we think about pandemics can really take some mileage out of. So if we imagine, like Rosenberg has argued, that pandemics are like a play, we need to know who the audience is, who the performers and the cast are, and where it's all taking place. And living through COVID-19, I think, has shown that we don't have those luxuries right now, or for most of the last year and a half, we haven't had these luxuries. A different way to frame epidemics, and one that I've been thinking about a lot lately, is around the idea of visibility. And what I mean by that is pandemics at once make certain parts of ourselves and our societies visible, and at the same time, they render others, ideas, structures, people, invisible. And I would argue, disentangle the COVID-19 pandemic of 2020 with worldwide protests for racial justice. Racism as a pandemic too is a model that emerged out of 2020, and it emerged out of a global disease pandemic, to be able to even use that metaphor. And the historical record of past pandemics reveals that we're not unique here either in this way, and that the broader pattern of what I would call infectious inequalities, in other words, the social determinants of health, the ways that race and class and gender and sexuality often determine who gets sick, who gets help, and who dies, are part of broader patterns here too. And so what the history of pandemics, I think, can help us to see and help us to be able to ask are some really tough questions. What and who is visible right now? Who is remaining hidden? And I think in a lot of ways, we have these built-in modernist assumptions about public health that we've sort of just inherited leading up to the COVID-19 crisis. We turn to epidemiology, to statistics, to maps, to biotechnologies such as vaccines. And we've heard a lot of a phrase now that historians have been familiar with and public health officials have been familiar with, but now everyone's familiar with. Quarantine fatigue is one of the reasons that people have been unwilling to engage in, have been more willing to engage in risky behavior. But there's another kind of fatigue that I've observed in the last year and a half, epidemiological fatigue. And what I mean by that is, at least for much of 2020 and in the first half of 2020, we saw every day the latest numbers on COVID from state to county to country, maps and maps and maps and maps, as if it was a political election cycle. And over time, what that leads to, I think, is some very real fatigue. Too many maps, too many numbers, too many people overwhelmed, and most importantly, a difficulty in trying to make sense of that science at a level of the everyday person. And I've seen that reality here, that fatigue here in Charleston, South Carolina. So we're a state that largely for political reasons, I would argue, was late to implement mask mandates and restaurant and bar and gym closures. We were lax in enforcing whatever mandates we had in place for a short time, and we were quick to reopen. And as a result, we've been one of the hardest hit states per capita in the US. And I think there is some very real research that people will pore over for decades to come that is going to be in the US alone, mapping COVID incidents and COVID deaths alongside the politics and the decisions of governors and state legislatures in those states. So I want to turn to a little bit of a different question here is how do we then trust the science? And that's part of what I've spent 15 years trying to study in the past as a way to reflect upon the present is the issue of science communication. How is it that scientific knowledge is produced, and how is it that everyday people consume scientific knowledge? And the reality is, all of you probably are aware, is it's incredibly complicated. Part of the problem is that it's never been that simple, that science is just produced in a vacuum and then everyday people just accept it. And that communication of scientific knowledge is inherently a cultural and political phenomenon. The questions of COVID are the questions that have permeated American society for the last 100 years at least. How do we package scientific knowledge for everyday people? How do we translate the most up-to-date science into actual policy? And what's more, how do we do both of those things, science communication and science policy, when the science itself is rapidly and even daily changing? That to me has been one of the most difficult parts of COVID-19 in the US in 2020 and now in 2021 is the science is happening in real time and it's changing almost daily and weekly in real time. And the communication of that scientific knowledge, and the policy is lagging, and it's sort of like been this perennial problem, and that no nation, advanced or otherwise, has been able to solve on any given scientific issue. And anybody that's interested in this question about scientific communication should check out a book by a couple of my colleagues, Naomi Oreskes and Eric Conway. It's a book called Merchants of Doubt, which explores the history of science communication on climate change. And it's a really terrific read about these bigger questions about science communication. In terms of pandemics, ambivalence towards epidemiology, towards the science of the spread of disease, is at the heart of our modern experience of pandemics. That it's a kind of biohistorical truism that while we experience disease in our individual bodies and selves, the pandemic is also inscribed onto our social body, onto our collective self in a society. And you know, in this way, the science of epidemiology, which is so crucial to understanding pandemics, it often belies the kind of politics of zip codes and skin colors, the search for patient zeros, both home and abroad. And in a way, you know, what we could turn to here, and I'll give you some historical examples to try to make kind of what these broad things that I'm saying here, my observations about pandemics, to crystallize them a little bit. And I'll turn to, this is a paper from 1870 by who was at that time, his name was Gavin Milroy, one of the leading epidemiologists in Britain, but really in all of the 19th century, who, in thinking about epidemiology and epidemics, he called the field of epidemiology, which he was somebody that helped to start that field, the science of epidemiology. He called it in 1870 stationary and unprogressive. How little we have yet really learned about epidemic disease, he casually observed. And I trust that in the past 150 years, we've made strides in the study of epidemics in the field of epidemiology, no doubt. But I think one of the things that's very clear to me as one of the small handful of scholars who study the history of epidemiology is that Milroy's sentiment still rings true in some ways, that as he observed, the general subject of epidemiology is indubitably mysterious and complex. And what he meant by that is it's very difficult to take the science of epidemiology and teach it to everyday people in a way that makes sense. So what has COVID-19 revealed, and how might we be able to use some of this history? One, I think, is perhaps the uncomfortable reality of emerging and re-emerging infectious disease. Now, if a narrow and just recent historical frame reveals that COVID, and we might put COVID alongside other recent global public health threats from the early 2000s, SARS, swine flu, Ebola, Zika. But if you take a longer historical frame here, we see something different emerge. So waves of epidemics of infectious disease defined the 19th century experience all across the world at the time that the field of epidemiology emerged, the time that Gavin Milroy was talking here in 1870. Cholera, typhoid fever, bubonic plague, yellow fever, malaria, diphtheria, scarlet fever, tuberculosis. They were all leading causes of death, rampant infectious diseases across the world, and in particular across the West. And then in the early 20th century, something really fascinating happened. In the West, what scholars refer to as the demographic transition, which saw the decline of those major infectious diseases and the rise of chronic diseases, to the extent that by 1950, the leading causes of death in the US and Western Europe were heart disease and cancer. That is pretty fascinating, I think, if you look at this longer arc of infectious diseases being part of our everyday landscape. By 1950, chronic diseases are the leading causes of death. And it wasn't until the 1980s, with the emergence of drug-resistant tuberculosis and then HIV/AIDS, that we saw infectious diseases coming back to the fore. And so in some ways, it's tempting to see COVID as just this new disease, this as Camus observed, something dropped out of the sky. But if you study the history of pandemics, what you really see is some real patterns of epidemiological incidence of infectious disease. We have just happened to be a population in the early 2000s in the West that believes that we're sort of been invincible to infectious diseases. When the reality, I think, is if you take this longer historical arc, a new pandemic of an infectious disease is almost, it was almost bound to happen here by law of statistical averages, let alone from what my colleagues in ecology have studied of the really more, I think, super complicated ecology of infectious disease and changing virulence levels of infectious disease, which I'd be happy to talk about if anybody's interested in that. Well, I want to turn a little bit and talk about a couple concrete examples from the past that I can use to crystallize how using some historical examples can help us to see through this moment and what we might take from historical examples, some of which you might be familiar with, and hopefully maybe not all of these. And I want to frame these around issues of rights and around cultural patterns of xenophobia. Pandemics produce a kind of conundrum that we experience them individually and collectively, as I've mentioned, a kind of interesting epidemic tribalism that we have. And if you're familiar at all with the work of famed biologist E.O. Wilson, you'll know that this tribalism he is described as one of the essential parts of our existence as social animals, not unlike the social insects. And even then, the tension between the individual, the local, and the global, it's been crystallized for us this year, I think, in some really deep, important ways. So the example that I keep coming back to is one from Michigan that happened in 2020 that I think, and I keep asking myself this, in 50 years, in 100 years, how are we going to write the history of COVID-19? And one image that just keeps sticking in my head is the one that happened in Lansing at the state capitol, where largely white, largely right-wing, and heavily armed, mostly men, stormed the Capitol building in Lansing, fighting for their individual rights to reopen the state of Michigan and to lift the governor's quarantine measures. I think that in some ways is a crystallized image of what this pandemic represents, and the ways in which pandemics are inherently political phenomenon to this same extent that they're biological phenomenon. And we might juxtapose in 50 years that image of armed men with ARs storming the Lansing Capitol alongside another set of 2020 photographs of thousands of Americans peacefully protesting in 2020 for racial justice and against gun violence, for a very different set of fundamental human rights, but yet doing so using the kind of reality of the pandemic and the pandemic response. So in this way, COVID-19, I think, like all pandemics, it hasn't created these tensions, racial tensions, cultural tensions, political tensions, social fissures around rights and race, but it has illuminated them and exacerbated them. And as you all know, much of the debate around COVID has been around rights and framed around rights and freedom in this country. But there's a history here too that I think is really helpful to understand, that of both individuals in the past making similar anti-quarantine, anti-public health measure mandates, debates around rights. So for example, in the 19th century, this freedom argument was there, but also we saw it there too, that citizens argued that they had a right to be free of kind of public health measures. My colleague Graham Mooney, who's at Johns Hopkins University, has explored this in an essay he wrote for The Atlantic that should be easy to find if you Google his name in The Atlantic, which I recommend. And what Mooney argued is that in the space of a few months, COVID-19 joined diseases like scarlet fever, diphtheria, and cholera as quintessential examples of a threat that requires giving up one sort of liberty in order for people everywhere to enjoy their right to be healthy. And so in other words, what Graham is saying here is that freedom is a flexible concept, that dominating discussions about rights have been part of this long-standing historical battle around rights and freedom surrounding infectious disease. One historical example that's prescient in this moment is that of Typhoid Mary. Mary Mallon was an early 20th century Irish immigrant cook. She was taken by New York City health officials, isolated against her will for over 20 years at the Riverside Hospital on North Brother Island. And the headlines rang out, as you see here, that she was a menace to the city's public health, the most dangerous woman in America. Mary Mallon was probably the most famous case of an asymptomatic carrier for typhoid fever, a food and waterborne disease that's spread fecally orally. So she's shown no symptoms of the disease, but was an active carrier and certainly did lead to several high-profile cases in rich families in New York that she was a cook for. Now, the epidemiological problem of typhoid Mary looms really large right now with the science, although it's still moving and still a little unclear, that the novel coronavirus can sometimes unknowingly spread in those that are asymptomatic. But Mallon's famous case and her infamous treatment is a reminder, I think, not just of the importance of asymptomatic carriers, but something else, that the reaches of public health and how in moments of crisis, class and ethnicity shape real-time decisions. So the fear of healthy carriers lurking in communities, her case shows, and I think we certainly have seen that fear still today. It's a burden that in the past and in continuing today that weighs more heavily on minority groups than others. And a second part of this, I think, is that, you know, and it's just as menacing of a reminder, is that the urge to identify an origin or a start to the pandemic can have grave and lasting consequences. And in the last year and a half, we've been obsessed in trying to pinpoint an origin of COVID-19. And those of you that are following will know that even just recently, there was a congressional session about this, of finding either the first laboratory in China or finding the first individual sick or the first wet market where this disease might have emerged. But as any of my colleagues in epidemiology or especially in disease ecology can tell you, the search for origins of a pandemic mutation like this are all red herrings at best. And that what has led to the emergence of a mutation of a family of disease, of the coronavirus, like what happened with COVID-19, is part of a very complex set of environmental ecological phenomenon. It's not the repose of one person or one laboratory to take that invented story about the origins of this. We want to find a typhoid Mary in COVID-19. But mostly I would argue what we really want to do is find somebody or something to blame. Now, undoubtedly, to take a different example, some of you have seen references to the last big pandemic that the world has had to deal with in 1918, 1919, the so-called Spanish flu. The comparison at first glance is a pretty good one, I think. Public health officials responded to that pandemic in 1918 in the fall by issuing quarantines and stay-at-home orders. Some officials mandated masks, most recommended masks in 1918, even though they didn't understand that the influenza that caused that pandemic was spread by a virus. They could see its epidemiology as being a respiratory disease. Businesses, churches, risky centers in the community, like movie theaters, shut down in 1918 and early 1919. And then due to political pressures, not unlike ones that we've seen in 2020, most of those state mandates were systematically in the winter of 1918 lifted, only to see a next big wave of the pandemic in early 1919. It's a kind of chilling, absolutely chilling pattern that happened in 2020 with coronavirus, that happened in 1918 and early 1919, of the politics of public health getting in the way of what the science of public health had even shown in real time. And in that example, as the one that we've seen now, there was pushback. There were questions about economics. There were questions about individual rights and about quarantine fatigue. But I want to step back a moment and kind of caution against too much, in putting too much either in typhoid Mary or in the Spanish flu into historical analogy. Historicizing pandemics as just issues of rights in the modern West has its own kind of danger, one that can deliberately leave out critical examples of those who were denied rights in the past. And individualizing pandemics just on issues of rights misses a kind of broader story. And it's one that I've seen in this country be, I think, the most important absence from our discussions. And that is that COVID-19, like all pandemics, are global phenomenon. And I think too much of the story of COVID has been a local story in the US and not a global story today, to the point where, you know, there are parts of the world that are in real COVID crisis that barely even make newspapers or popular coverage in this country. And we're dealing with an organism that is both mutating quickly and does not know geopolitical boundaries. And I want to just highlight with a couple examples why this is so important and for how long people that have been studying epidemics have shown this to be true. The field of epidemiology, and this is coming out of my own personal scholarly research on the emergence of epidemiology as a science, have from the late 19th century, when that field kind of took shape, of the academic field of epidemiology, but then the practice of epidemiology by governments, something that we just take advantage of today, that they're people that we put in charge that are experts that study disease phenomenon and help us to make real decisions. That started in the late 19th century. And if you've looked at pandemic archives like I have in the field of epidemiology, what you see are maps like this. This is a world map that was created by a German doctor in 1852. And this was an attempt by Heinrich Burkhaus to map diseases onto climatic regions that were considered important or valuable for 19th century Europeans, where they might travel or colonize into Africa, Southeast Asia, South America. But what Burkhaus was really interested in here is to see and understand already by 1852 the global spread of disease, and to map on what we now would call the ecology and the environmental factors in the spread of disease. This isn't a political map. This is a map that's trying to understand the spread and visualize that spread of disease around the world. Just to give you, and I could give you hundreds of these examples from my own research. Second example here, slightly later, from 1892, by a British Army epidemiologist, Robert Lawson, who is studying the spread of cholera and its movement across the globe. He spent 30 years studying cholera and how cholera spread throughout the world. He came up with this whole wonky theory about epidemic waves, who he was relying on a cutting edge scientist who studied electricity in the 19th century, Michael Faraday. And Lawson tried to argue that energy flows from the North Pole to the South Pole influenced how and why cholera erupted and spread over the earth. Now, his wave theory, of course, is completely discounted. But what I'm trying to point you to here and help us to understand is that this kind of thinking about disease, that disease is a global phenomenon and needs to be understood environmentally, ecologically, and across geopolitical boundaries. You noticed here that this world map doesn't really make a geopolitical statement. It makes an ecological statement about the relationship between host, pathogen, and environment. And you see it in another map here from 1894 from R.W. Falcon from the Royal Geographical Society. You see the continent of Africa and the incidence of disease all across Africa. And you notice here, and this is the only point that I'll try to make to you, you see this as being, this map as being devoid of geopolitical, ethnic, or cultural boundaries in favor of pathogenic boundaries, zones where different diseases are more prevalent than others. And what I would argue is from the late 19th century, from the very beginning of the field of epidemiology, there's been a kind of globalizing ethos to understand pandemics as broader phenomenon. And that's something that I think has been actually missing in our discussions of COVID-19 today. We've almost hyper localized COVID too much, particularly in the West. And we've kind of moved away from what is this very long tradition of understanding disease as spreading globally and needing global solutions. And part of that is, I think, this other really interesting phenomenon that's happened that has a history of early in the pandemic in 2020, former President Trump disavowed the World Health Organization and pulled out US from the World Health Organization, or attempted to do that. And that I think has had some really grave consequences, not just for public understanding about COVID-19, but as going against this very long history that began in the 1850s of countries coming together. And this is something that very few people realize, that this ethos started in the 1850s of countries coming together and saying pandemics they don't recognize international boundaries. And so we need global solutions to understanding and stopping the spread of disease. And you just see, I show you some early publications on that topic here. And throughout the history of pandemics, in addition to the global feedback, I think there's also been a kind of pushback in the past on the global, on the limits of government authority. And this is something that, I think is important context at the same time. So pandemics archives are littered with these anecdotes, like this one from 1858, when disgruntled residents of Staten Island set fire to a 60-year-old quarantine station. This was a result of waves of yellow fever and waves of cholera, and working class citizens who were forced into those quarantine facilities. They rioted. There's similar examples littered across the US, particularly in the 1890s with immigration officials in Ellis Island, who turned their inspection and pathologized gaze onto newly arrived immigrants, particularly from Eastern Europe. And so as much, I think, as pandemics are inevitably ones that we need to see as global phenomenon and as issues of rights, they're also ones that I think we can see as having this longer history. I want to just mention really briefly before I move on here, the way in which there's this longer history that I mentioned of patterns of xenophobia and blame. And I'll just give you some brief examples on this, because I could go on and on. The two that really strike me as resonating the most are in the 1830s, cholera, which is a food and waterborne disease, indigenous to Southeast Asia, erupted because of European trade and colonialism spread throughout the world. 1831, cholera arrives in Western Europe. 1832, it arrives in the US. And the imagery over and over again in waves of epidemic cholera is that cholera was Indian, cholera was Asiatic, cholera, as one British official said, came from India, where parents sold children, where they ate and drank the blood of frogs, dogs, and serpents. And I bring this imagery to you, and you can see some of the iconography surrounding it at this time, is that there's been this built-in historical memory that when a new diseases emerge, we need that blame, we need that other to try to find. You see this throughout Western Europe and North America. Again, this sort of framing of cholera in the 1830s. Where did cholera come from? And you see it again in 1900, the emergence of the last big pandemic of bubonic plague that swept across the world, beginning in the 1890s and lasting until about the 1940s. You saw it here too. Plague struck in the US, it struck San Francisco, the West Coast port the most. And there, what we saw was US officials who blamed it on newly arrived Chinese immigrants, cordoned off Chinatown in San Francisco, most notably, and forcibly removed Chinese Americans to detention centers. Again, the science of disease communication not matching up with the cultural sensibilities of finding someone to blame and trying to isolate them from someone else. And I say this, bring this up because in 2015, the World Health Organization set guidelines on what they called the naming of new human infectious diseases, with the aim to minimize the unnecessary negative impact of disease on names, on trade, on travel, on tourism, on animal welfare, and to avoid causing offense to any cultural, social, national, regional, professional, or ethnic groups. This was a document from 2015 that the WHO set. And basically, it was an amazing, thoughtful, meaningful, historically nuanced set of guidelines for countries all across the world. And yet, when COVID-19 emerged, what we saw was a reverberation back to long-standing patterns of blame. I want to mention just in some brief time that I have left here, and then I would love to talk more about any of these matters with you, what we can do and what all of us can do. More than anything else, what COVID-19 has helped me to be able to see as a historian of pandemics is the way in which we need to record voices during this pandemic. And as someone who spent my career studying past pandemics, I can tell you that the voices of everyday people have mostly been forgotten during pandemic moments. How you feel right now, how you felt the last year and a half, is not how you'll feel in 10 years or 20 years. And in fact, I think there's already been enough time lapsed in the last year and a half that some of you may even be murky on what you were doing in February of 2020 or March of 2020. And for that reason, that silencing of the past that we've already seen happen, I've been part of, and there's people who are doing this work all over the US and they're doing it all over the world, of creating COVID-19 archives. So I led a project in Charleston where we've collected, we're up to about 290 oral history interviews of people that live in the Charleston region that we are collecting and we're digitizing and we're making transcripts of. Everybody from doctors and nurses and frontline medical professionals to students. I've had a bunch of my university students submit their own pandemic journals to this archive, to custodial staff at the hospital. I interviewed and recorded some of the city garbage collectors from Charleston to record their everyday experience of the pandemic. And these voices and saving them in archives I think will help us to tell more nuanced stories. So much of the past of pandemics has been through the lens of politicians, through the lens of scientists, through the lens of doctors, and not enough through the voices of everyday people. And so I think there's a real opportunity here. I don't know of any similar projects that are happening in West Michigan, any COVID-19 archives projects, but I wouldn't be surprised if there aren't some happening right now. And maybe what I need to do actually is start reaching out to some of my contacts in West Michigan, because these stories all across the country are the kinds of ones that we need to preserve. And I'll just give you just a very brief example here. You can go back to this in the recording if you want, but this is just from one of my classes last year of having my students as part of their assignment is keeping a weekly journal, and just to see the real gravity of the emotional response to keeping a journal during a pandemic, of what that really means and what that can mean for us as historians going forward. So I want to just leave you with three thoughts here of COVID's future, or maybe four thoughts here. One is that I want to make very clear, and I say this to everybody that I talk to about COVID-19, is my biggest fear of COVID is that it will become just another, what I call a disappearing disease. And what I mean by that is cholera, tuberculosis, yellow fever, malaria, typhoid fever, the list goes on and on. These are diseases, infectious diseases that the West struggled with for hundreds of years, that in part due to vaccine solutions, in part due to public health infrastructure that we have quote unquote conquered. I don't have to worry about my children drinking water out of a tap in Charleston or anywhere else in the US and contracting cholera or typhoid fever. Yet in many parts of the world, in Africa and Asia and in Latin America, those diseases are still leading causes of death worldwide. Most American students, when they get to my classroom, they've never even heard of these infectious diseases. Some students don't even know how to pronounce the word cholera. They look at that word on the syllabus and they're like, I don't know what is that? I don't know what that means. And there's a history here whereby in the West, once we've quote unquote conquered a disease where its incidence becomes low, we shift the burden to other places and then we just forget about it. We put blinders on. It's not our problem. It's out of sight, out of mind. And I'm afraid that even as we get COVID under control in this country and in the Western developed economic world, that COVID will be an entrenched problem of the global South for decades and decades to come. I have colleagues in Nigeria, just as one example, some close colleagues that I did a postdoc in London after I finished my PhD at the University of Minnesota, and my wife and I spent a couple years in London. And at University College of London, where I had two Nigerians who were historians of medicine and disease, who are now live back home in Nigeria. And I've been contacting them through email over this past year. And there are no vaccines available for Nigerians, just like for COVID, like most of the global South. And so for as much as people in the US think that we're over COVID, even though I looked at rates this morning that are 60% up in most counties in Texas of daily increase. So, with the new variants, we still have a lot to be concerned about in this country, but I think we really need to be concerned about what my 19th century epidemiologists were so attuned to is the global spread of disease needing global solutions. Secondly, is that you look at some of the literature that's coming out today and what is unfolded in the last year and a half, and what you see from a social science perspective is that COVID in 2020 struck people of color in the US at a 3 to 5 time rate higher than it did of anyone else. That is something that we need to address moving forward. COVID has not created health inequality, it's exacerbated health inequality, but the social determinants of health, why it is that Black mothers have a 10% increased rate of dying in childbirth and postpartum, why it is that people of color, and especially in urban areas, have such different health outcomes than wealthier white citizens in the US. Again, COVID has revealed that to us, to many of us, to those that don't study it. But going forward, I think we have an opportunity to use the pandemic as a way to invest in particular kinds of public health solutions. And if we don't do that, then the next time a pandemic rolls around, guess what? It's going to strike people of color and people in urban areas greater. The next is one that it's a takeaway lesson that's a little complicated. It's reframing what I call the historicity and the ecology of disease. We tend to think, most people in the US in particular, that COVID-19, like all other diseases, are stable entities, that it's just a thing that exists in nature, and that when it just spreads from one place to another place in a linear fashion. And for those of you that have been paying attention the last year and a half with COVID, or took some classes in more advanced biology in college, what you know is that COVID-19, like most other infectious diseases, are evolving and changing way more rapidly than we as a human species are able to keep up with them. And COVID, I think we have an opportunity, because of the experience and the coverage of COVID-19, to see diseases in this ecological way, to see them, and the reasons for COVID mutating and spreading are just as tied to bigger questions of our human role in changing the environment. And finally, I think this is a point that I've already mentioned, but I'll just underscore it as one last one, is that at no point in recent human history have we been able to come up with a global solution for pandemics. This is despite 150 years of specialists, people that I explore in this book, The Filth Disease, that have clamored for 150 years in saying that the only way to address pandemics is through global cooperation. And it's the same kind of global cooperation we need on climate change. And moving forward, if we don't use COVID-19 as a springboard to talk about global solutions in public health, then the next time the pandemic rolls around, it might not be in your lifetime, it might not be in my lifetime, but I can assure you that if it's not in my lifetime or your lifetime, it's going to be in my kid's lifetime, that there'll be another pandemic. And if we don't do something between now and then to move towards some broader global geopolitical kind of agreements about what are universal human rights around public health and disease prevention, then we will not have left the world in a better place once we've left it. So these are a bunch of scattered thoughts from a historian, and I'll really look forward to your comments and questions. Thank you. And I'll stop my screen share.
Thank you, Jacob. There are 4 questions in the chat, and if you'd like me to just go through them in order, I don't think they're visible to you. And then we can open it up. You'd mentioned early on your young children, 3 and 6, are not vaccinated. It's not approved by the CDC at this point. Is there an age that you would approve them getting vaccinated, or do you know what your position is as a parent on that?
Yeah, it's a good question. It's a tricky question. It's one that I think the science is still pretty rapidly changing. I know of one clinical trial that's happening right now in Arizona that is, I think, age cohorts 10 to 12, and that study has been very promising in the immunological response of those young people. And I will not be surprised if we roll out 10 and hopefully even younger. I think the problem is, and I could talk circles around you pharmacologically, but it's the same problem that we've had for about 50 years now of understanding drugs and immunological responses, is that kids react differently than adults to all sorts of things. And so, I think if a coronavirus vaccine passes the kind of standard testing that we've seen for approval for adults that have gone through 3rd stage clinical trials for children down to 8 or down to 6 or whatever it's going to be, then I will be, clamoring to get my kids vaccinated for sure. So at this point, it's just sort of a wait and see approach. I do know from a colleague that clinical trial that's happening in Arizona right now, there were parents all across the country that were willing to drive their kids there to sign up for that study, just to be a part of that study. So it's kind of interesting too, to think about the research ethics, and there's a long history there of being and participating in clinical trials. I actually was part of a clinical trial myself in 2020 for the Novavax vaccine, which is very, very interesting to be a part of a study myself.
Mm-hmm. That's great insight. Thank you. 3 more questions that I currently have. Do you think that the AIDS crisis in the late 1990s and 2000s was a pandemic?
Yeah, it's a really great question. The research on HIV/AIDS, both historically and biologically and epidemiologically, has been super fascinating. I mean, there's been some research, some ecological research that's shown that the virus, HIV, that causes AIDS has actually been around in human populations from the early 20th century. And that rates of HIV certainly did explode in the early 1980s, but there's a longer history than we've even seen there. I think that by the 1980s, when there was a name, and you will recall, and those of you that were there around and paying attention in the early 1980s will remember that the first name given to that disease was GIRD, gay-related immunodeficiency. that there was a belief that started because of one tiny little article in the MMR, the Morbidity and Mortality Report of the CDC, that said that there was a group of 14 gay men who had this disease in Los Angeles, that led to this broader entrenched stereotype that HIV is somehow a gay disease, when in fact we know epidemiologically speaking it's not. It's a disease that has epidemiological pathways, but it's not a disease that's particular to any community. I think HIV is probably best described as an epidemic disease, at least as it was in the US, but it has spread across the world in pandemic fashion to the extent, and I think we've seen this, I mentioned at the end that my fear of COVID becoming a disappearing disease. Well, HIV/AIDS has become a disappearing disease, in the 2000s, to where, I remember as a child in the 80s and the early 90s, constant campaigns in schools and posters in schools about the dangers of contracting HIV/AIDS, real public health campaigns, and I don't think we have those same campaigns today, even though rates of HIV infection still remain incredibly high, particularly in urban areas in the US. We've sort of shifted the blame in many ways to saying that, well, the biggest instance of HIV is in Africa, and we sort of shifted the blame then.
Thank you. What do we do when a vaccine is approved and people refuse it and die? Rural areas and poor urban neighborhoods is specifically what this person is citing.
Yeah, it's another really terrific question. Yeah, I mean, at some point we have to come up with some tough solutions here that are public health solutions, right? And inherently, public health solutions, the whole field of public health in some ways drew in the 19th century when it emerged in the West on utilitarian philosophies of creating the most public good for as many people, and in doing so, the early forerunners of thinking about public health as a government entity believed that we might have to, in times of crisis, suppress the quote unquote rights of some individuals to protect the broader community. And there's always been that tension in public health. And I don't think that, vaccine rollout of COVID-19 is anything exceptional to that. And I'll just give an example that I've actually been personally debating, I think is an interesting way to put it. Fighting, I think, is a better way to put it, is I've served on our university's task force for COVID-19. We meet every single Wednesday, and usually it takes a couple hours, and it's our senior administration for our university and a couple faculty members. And our administration has made the decision not to require vaccines of students or faculty for the fall. And so you can enroll in the College of Charleston, or you can teach at the College of Charleston with no proof of vaccine. Many other universities across this country and across the world have said, you can't come to campus unless you're vaccinated. You can't do it. You can't move into the dorms. You can't teach class unless there is a very real immunological reason, of which there, yes, are some very few exceptions, that a licensed doctor has said that you getting the vaccine would be dangerous to your health and harm your health. If you have one of those, it's a get out of jail free card. If you're an adult and you're unwilling to get vaccinated, then you're not coming to our campus, because you're going to harm the rest of us, or those of us that have children that are unvaccinated. And so I think it's a very small example, but it's one that I think going forward, we're going to have to grapple with. And the reality is we've grappled with it with a whole host of other infectious diseases. Most universities have policies that you have to be vaccinated for a whole swath of infectious diseases and show those vaccination records before you can enroll as a college freshman. The same goes through our public schools. And so what I told our university president at a recent meeting is, we require vaccinations for all of our students for about 8 infectious diseases. Why can't it be 9 infectious diseases? And the reason is because of the charged politics around COVID-19, and nothing really else. And so yeah, I mean, to answer that question, I think that I certainly have my own personal public health views on requiring vaccination for some institutions, particularly public institutions. Outside of that, I think that we have very little government control outside of public institutions for requiring vaccination, just based on our legal framework in this country.
Okay, thank you. A few more questions have come in. How much impact do you think that Bill and Melinda Gates Foundation has on a global response to diseases and pandemics?
Yeah, I think this has been the kind of result of there not being systematic international collaboration and cooperation with trying to curb infectious disease, is that we've sort of left it up to this neoliberal approach of private philanthropy having to come in. And the World Health Organization is a very interesting one in its history. It was, of course, tied to a European-centric organization that tried to go across parts of now the global South and implement strategies for disease eradication. Of course, the only successful one to speak of today culminated in 1983 with the eradication of smallpox. Other than that, a lot of the World Health Organization initiatives have been less successful around yellow fever, malaria, and cholera. However, I think we've seen in the absence of even widespread success by the WHO, we have seen some success by philanthropic organizations, private organizations who have used capital and the raising of capital to implement public health strategies. One that I'm most familiar with for the Gates Foundation in particular is efforts for cholera eradication through establishing pure water supplies in Central Africa. So certainly there has been some impact.
Mm-hmm. Thank you. What is your feeling or opinion of the Novavax vaccine? Can you speak on its differences from the others?
Yeah, Novavax is interesting. What the studies have shown on Novavax is that it for many of the COVID-19 variants that have emerged in the last 6 to 8 months, that Novavax, which doesn't rely on mRNA technology like the other main vaccines do, is that it's been quite successful. The Novavax is made from a spike protein from the coronavirus, and it's shown to be the most effective, even better than the Pfizer vaccine against some of the new variants. And so that's another big question that I hope we don't have to, knock on wood, grapple with, but we very may have to grapple with, is if the longer that we let, and I'm speaking as from my knowledge of disease ecology and the evolution of infectious disease here, the longer we let COVID-19 just exist in the wild, going through human population, the more it just cycles and keeps finding hosts, the greater susceptibility we're going to have as a human species to it changing and adapting and morphing and mutating. And we don't know. There's not an infectious disease specialist in this world that can tell you what the next variant or the next mutation is going to hold in terms of its virulence, how lethal it is to humans. But what we can say is that the longer we let it mutate, the greater chances are going to be there for the potential that the vaccines that we have developed right now will be ineffective against some future version of COVID-19, maybe requiring a new vaccine, maybe requiring some different kind of immunological booster. So that's still yet to be seen, but the longer we let it be out there, the greater the chances.
Okay, so look at your historical knowledge. Someone asked, do you believe that the forced quarantining of Typhoid Mary was the correct public health decision in New York back in the day?
Yeah, it's an example. I mean, that's a question that I pose to students when I teach this topic every single year, and I think Typhoid Mary, she was a woman and she was Irish, newly arrived immigrant. She was unfairly singled out. I've read really carefully, and I've published on this, the reports by the New York City Health Office, whose public health officer at that time was a man named Herman Biggs. And Biggs had identified at the same time that Mary Mallon was singled out over 100 healthy carriers throughout New York City that were positive for typhoid fever. And Mary Mallon was the only one that was imprisoned for being an asymptomatic carrier. In part, that was because, and there's a really great book on this by a colleague of mine, Judy Levitt, and a good documentary series on PBS that's some years old now. But Mary Mallon, part of her chief problem is that she never believed that she was sick. She never believed that she had typhoid fever. So, the officials would take her stool sample and her blood sample, and they would say, here, at one point, one of the bacteriologists actually brought her to a microscope and said, look, here are the colonies of typhoid bacilli. This is what's making people sick and die. And she just refused to believe the science. So should she have been imprisoned on an isolated island for over 20 years? Probably not. But was she a potential health threat to the community? Absolutely.
Interesting. That is all I currently have in the chat. Let me just go through it one more time, make sure. Somebody had asked about the polio scare in the 1950s. Do you have any insight on that? Maybe is that a pandemic or any feedback? And that looks like the last question that I have. So if you want to open it up to the floor after you address that.
Yeah, polio is another great example. One that, I teach and I've looked into. Polio is most interesting, I think, because by 1950, as I had mentioned, the leading causes of death in the US are heart disease and cancer. And yet, what we saw in the US in the 1940s and the 1950s in particular is a massive campaign to attack polio. And there's, the March of Dimes organization begins as a presidential attack to attack this disease. And you see, FDR himself, a polio survivor, disabled by the disease. You see this ramping up of polio as the darling disease of the 1950s, when the leading causes of death are heart disease and cancer that get very little until the emergence of the National Cancer Institute and funding through the Lasker Foundation of the National Cancer Institute. And so what it goes to show, I think, as an example, is that at any given time, and this is why public health is so important to study from a kind of historical, cultural phenomenon, not just a biological phenomenon, is that it's never as simple as, here are the 3 leading causes of death in this country right now, and here's where all our money and our efforts going to go. It's never been a one-to-one equation like that. There's always been political calculations as to where do we invest our money, where do we send our resources, what are our public health campaigns going to attack. Polio, I think the consensus is, and there's a great book on this by Dave Orshinsky, is that polio was the darling disease of the 50s because polio attacked children, and polio was a disease that virologists were fascinated by for how to create a vaccine. And there's this famous debate that happens between trying to find a live vaccine solution or a deadened vaccine solution that Jonas Salk eventually cracks the code on. But it's a disease that isn't just as simple as leading cause of death, so here's where we need to pool our resources.
Is it okay if I ask a question now?
Yeah, go ahead, Russ.
I started medical school in 1982, which is right before GIRD. And I was working in a hematology lab when they found out it was HTLV3. You know that acronym.
Mm-hmm.
I think HASP is deeply rewarded by having someone who is a student of pandemics speak to us today. For me, this last 18 months has been like returning to medical school in the 21st century, learning all the new things about how we learn things. And there's a parallel between your comment, students as historical agents, and what the Michigan State College of Human Medicine taught me: patients are my best teachers. And the comment I request of you is the role of completing the Human Genome Project 21 years ago has in the present day, and how amazing it is to me that Tony Fauci took his job when I was in medical school, and they still have not found a vaccine for HIV. Short answer, please. Ha, ha. I get it. I'm mute.
No, thank you so much for that, for those comments, Russ. And yeah, I mean, it's I don't even know where to start there, but you know, we're still for as much incredible scientific progress that has been made in the last 50 years, but I'm thinking about myself and with my research, some of the, you mentioned the Human Genome Project, and some of the coolest research that I geek out about as a self-prescribed geek is in those scientists who are studying and mapping the genomes of infectious diseases. So there's all this incredible research that is happening in real time. So, you know, one of the hot button ones that I'm fascinated with, and, you know, a lot of people are geeking out on, is mapping the whole genome for bubonic plague and trying to understand where all of the genetic variations have happened, both at a horizontal level and at a vertical level of evolution and mutation, for how that genetic sequencing for that particular infectious disease has happened. Why I'm so fascinated by that is that what that gives us is a historical study of sorts. It's a historical map of how that disease has changed over time. And I'm working on a couple projects right now with some colleagues in infectious disease research who are doing that kind of work. And I'm being brought into a big projects for a couple big NSF grants that we're trying to work on, that are saying, if we can use that genomic research and then map it on to the historical research of disease, we might actually be able to come up with some, you know, some real evidence of how and why different diseases mutate and change in real time, in order to be more predictive about the science. But, you know, why we haven't come up with a vaccine, an effective vaccine for HIV, why we still have so many gaps in the cancer, you know, the cancer story is something that maybe will get solved in our lifetimes, but maybe not. But maybe not.
Can I add something there, Jacob?
Yeah, please, Richard.
The diseases you've mentioned versus the work that Jennifer Duda has done at Berkeley with single gene diseases has shown that these diseases are so complicated, for example, bubonic plague, schizophrenia, that right now we just don't have the techniques to go in and hit 2 or 3 or 4 or 5 sites in the genome. Schizophrenia, I think they had figured out there's 23 different sites that are abnormal, and we just don't have the techniques to do that. The single gene with CRISPR is being has went forward until the Chinese went over that red line and started doing with the germ line. Yep. But I think we got a lot of diseases going. The Human Genome Project has given us the information about where every disease is on the chromosomes, but we haven't figured out how we can modify a disease where there may be 4 or 5 or 6 different genes at the same time.
Yeah, really, really great comment, Richard. Thank you so much. Yeah, and I've been following this CRISPR story. I've been teaching it since we first, even had the acronym of CRISPR, and I usually have a module at the end of my classes, and it's about biotechnology in the future of biotechnology. And students love to talk about this. It's one of the great topics that we end up discussing in the course of a semester in the history of pandemics and public health is, about gene editing and about, the not just the ethical guidelines around gene editing and where those lines, as you mentioned, might be. But with what the future from a technological standpoint is for trying to prevent, in particular, or treat diseases that are continue to impact our populations.
Interestingly, James Watson, who was Watson and Crick, who found the DNA sequence, his son had schizophrenia, and yet he supports editing even the gene line now. And he's been a radical, shall we say, voice against some of the ethical dealings that we were accepting.
That's interesting. I didn't know that. Thank you for sharing that. Yeah, I didn't know his son had schizophrenia.
I've got a question. Compare somebody who has had COVID to somebody who's vaccinated. How are they equal or not?
Yeah, I mean, in terms of immunological protection, is that what you're asking, right?
Yeah, right.
Yeah, I think that what the research that I've read suggests is that if you get COVID and you survive an attack of COVID, your body has built up an immunological response to it. And if your body has been vaccinated, it has built up an immunological response to it. I think where your question lies, and I don't have the answer for you as not an infectious disease researcher, is, what are the long-term immunological benefits of either getting the vaccine or getting COVID, quote unquote, naturally, as we might say. I think it's a great question that,
We've got 4 visitors and 3 are vaccinated and 1 has had COVID who did not want to get vaccinated.
Yeah.
The problem is that the person who's had COVID may still be able to transmit the virus.
We know that for sure.
Pardon me?
Yeah, we know that for sure, that even if you've had COVID, you still can get the disease again and transmit it to someone else. The epidemiology on that's pretty clear.
But those who've had the vaccine seem to have a much lower chance of spreading. Well, they haven't had the virus. The virus has been, shall we say, eradicated from their body by the vaccine. Whereas those who've had the virus can still be, a quote, I use the term typhoid Mary. I think, Jacob, my colleague, Dr. Kobes, and I just gave a talk on germs yesterday. We talked about the non-vaxxers versus the anti-vaxxers.
Mm-hmm.
The non-vaxxers are people who don't understand science and who are concerned because of racism and the racial inequality of healthcare, like you mentioned. The anti-vaxxers, we've traced anti-vaxxers back to 1825 when there was anti-vaxxers against smallpox. So the anti-vaxxers have many other reasons why they're opposed to vaccinations. One is that we, quote, don't need vaccines anymore. And number 2 is that that it's against God's will, that we should let the world just run its natural course, which is something I can't accept, but that's the way. But we realize that today's world, I think there are non-vaxxers and there are anti-vaxxers.
Yeah.
The non-vaxxers can be bought, can be educated.
Yeah. Yeah. No, I think you're right that it's in part a question about science communication. in one respect, as you call the non-vaxxers, but the anti-vaxxers are ideological. And there's a long history of ideological reasons for people, in particular in this country, although not exclusive to this country, to be against not just vaccinations, but large-scale forms of public health-based intervention upon individuals or upon communities. And you're right that we haven't found a great way to solve the problem of the anti-vaxxers. Yeah. I mean, I think ultimately, I'm an educator, and so ultimately, I believe in the power of education in addressing and all kinds of social problems, but in particular problems of public health. How most, when you mentioned germs, and in the 1870s and the 1880s, when a small group of, and really it's a tiny group of scientists who are working in laboratories, mostly in Western Europe and in North America, discover that infectious diseases are caused by bacteria, or at least some of them are. The way that tiny set of laboratory findings changes people's complete worldview and their everyday practices, it didn't just happen overnight. And it was extremely controversial. It was so controversial that in the 1890s, when Robert Koch, who's one of the great scientists of the late 19th century of bacteriology, he not only makes a whole slew of discoveries over the bacterial origins of infectious disease, but how to do the research of the microscopy and the bacteriology of staining and photographing in bacteria. He announces to the German Academy of Science that his discovery of cholera is from this Vibrio cholera, this bacillus. And one of his colleagues stands up in this professional meeting and takes a broth. Koch is walking through his scientific colleagues, and this is just his scientific colleagues, showing them how to do this bacteriological research and that this germ is the origin and the cause of this disease. And one of his colleagues, Max von Pettenkofer, picks up a beaker that's full of diarrheal discharges that Koch was using. And he just picks it up and says, there's no way that this bacteriology germ theory thing is true. And he picks up this broth of diarrheal discharges and he drinks it. Just to prove that, this new science was all bunk. And it's an instructive lesson, I think, about at any given time in history, and in particular about the history of science, that there are mainstream ideas and that there's people working to cut across and innovate and come up with new ideas and practices. And that process by which science changes over time is one that's fraught with complexity. It's fraught with people that are denialists, both within the scientific community and outside of the scientific community. And it's one that requires consistent communication about science. And I think in part that needs to happen in our public schools, and it needs to be systematic.
Okay, I have to make the announcement that we are sadly not only out of time, but a little bit over time. So if you have prior commitments and you need to drop off right now, you're certainly excused from class. But Jacob, if you are willing to stick around for a minute or two more, and there's anyone else that wants to open their mic and ask a question, by all means do. I have somebody who's inquiring what happened to the guy who drank the germs, which is
Right.
a nice way of stating what you just gave a visual to.
So Pettenkofer drank the diarrheal discharges. He got sick, but he didn't die.
Wow.
Did that change his mind?
He died. He died several years later, still believing that diseases were caused by rotting effluvia miasma in the atmosphere. Didn't change his mind.
Mm-hmm. Does anybody else have any questions that we could pose before we wrap up?
Yeah, I do, Susan. Jake, this is Kim. You talked about the aspects of the pandemic being both biological as well as cultural or political. And as an historian of pandemics, have you seen or are you aware of any time in the past when there were cultural or political efforts which were pretty effective in dealing with the pandemic that was out of control? Maybe they were just small and isolated cases, but to me, it seems like human nature is what it is, and it doesn't evolve very quickly.
Yeah.
And so I'm curious, can you point to, hey, here was this little situation in 1902 over in Timbuktu where they did it right?
Not really. I mean, the one example that does come to mind is in the early 20th century, all across the US, and this was happening in little tiny towns in the Midwest, and it was happening in big metropolitan towns, is after the discovery, and it actually was this guy, Robert Koch, that tuberculosis is caused by a bacillus, that there was this massive mobilization that was grassroots largely of community organizations raising awareness about tuberculosis. So in 1900, TB is the leading cause of death in the US. And TB is like, it's an epidemic infectious disease, but it's like a disease in slow motion because you can get TB and you could live with it for decades before it spread throughout your body, and then you got super sick and emaciated and eventually died. But TB in the early first decade of the 20th century, it became this disease which everyday people sort of galvanized around to raise awareness around it, and community marches and community big philanthropic kinds of pushes for trying to come up with a solution for TB, raise awareness for TB, funding tuberculosis sanatoria became this very popular thing to do. So I think the successes in public health for tackling infectious diseases, when we've had them, they've been ones when we've had broad scale community buy-in.
If I can add a short question, you just used the phrase raise awareness, and I'd like your thoughts on how this episode of learning and healing can raise awareness in how businesses work and where people work at home or not.
So help me to understand your question, Russ,
I think that this COVID experience will change how businesses operate in terms of having people at home, lowering their overhead.
Yeah, no, I think you're absolutely right. I mean, I think we've already seen, some pretty big changes. I've been talking to some friends about this around the country about, that work in the business world of businesses already changing, adapting. So much of the 20th and the early 21st century business model depends on, office space and office rentals and overhead and the whole infrastructure of the business world, economically speaking. And I think what COVID is not created, but it's certainly pushed is how productive some people can be in some fields in the business world from working remotely or working partly remotely. And I think we're going to see a sea change completely. Not all moving towards virtual remote kinds of work, but I think in terms of workplace productivity, in terms of individual health, in the health of corporations and the lowering of overhead costs, I think you're going to see a ton of companies who are moving towards a more flexible model of work and hopefully work-life balance too, because I don't speak from a lot of personal experience here because I haven't had any work-life balance in the last year and a half because I've been working from home, but I've also been doubling up as childcare provider. But what I can say is that I exist in a job within a corporation that is a university, but it's still in some ways a corporation. And in non-pandemic times, my kids are in school and I'm sometimes in the classroom. I can work from home a bunch. And I truly believe that I love my job and I have an enormous, again, non-pandemic times, have an enormous work-life balance and an overall health. I can go for a walk go, outside and go for a walk. I can go to the gym. I can play an instrument. I can do all kinds of things because of the flexibility of my job, that I don't have to just be sitting in an office somewhere. And that's been a privilege of people like me who work in universities for a long time now. But I think a lot of people in the corporate world, even companies like Google, I had a conversation with a friend who works for Google out in the West Coast. And he was even saying that, Google's a good example of a company who long before the pandemic wanted to create more spaces at work and these big campuses that had these amenities and more kind of balance. And maybe companies like that they didn't see it coming, that maybe the solution was more work from home than make work more like home.
Louis, I have a question for you, the educator, and I'm addressing this as well to whatever educators are in the group of 30 or so that remain. Our high school students go through 4 years where they are exposed to the foundations of chemistry, physics, and science, and biology. And yet, it seems to me, and this is perplexing, that the American adult population as a whole doesn't seem to have much foundation in science, and science in the past 18 months has taken a beating in this country. So my question to you and to the others in the group is, where are we going wrong in terms of laying down the foundation of what science is and how important it is in our lives?
Yeah, I mean, Louis, you hit the nail on the head here. I mean, there are people who study this phenomenon, and you could look across the world, and you could see science education in K through 12 schooling and how different it is, not just in terms of what kind of science is being taught, but how everyday people interact with the scientific process. And so, we've seen this a lot with COVID, is so many people uncomfortable in the US with not having answers about COVID-19. And what I kept telling people over and over and over and over again is, what we're seeing is science work. And it doesn't work overnight. It's not as if like that science, like let's just say infectious disease scientists, specialists, just to give an example here pertinent to the pandemic. It's not as if ID specialists just had all of the answers for COVID. And so once now there's a problem, they can just apply. What we saw is the science was changing in real time, and that's how it's supposed to work. And I think, you're right that there are some fundamental problems with educating K through 12 people as to how science works in real time, not just the knowledge of what exists in terms of what do we know today about biology or virology or, whatever the body of knowledge is. But more importantly, I would argue, is getting young folks in particular to understand what the process of science is, not just the product of scientific research.
I understand. Thank you.
Well, it looks like it's really time to wrap up. This has been an amazing class, so much information, and we appreciate it. I know a lot of people have dropped off, but I think I can speak on behalf of everyone. Thank you. Thank you for putting this together and for participating with us. I'm going to go ahead and stop recording. And then if Kim, you have any final comments?